or slide from the QR code that you receive at the registration. And don't forget to do the evaluation form because after we finish the evening session, same as yesterday, 3 lucky person, we're gonna get the free beautiful polo shirt like mine. And if you need free Wi-Fi, you can ask for a Wi-Fi password at the registration area. I think the slide is ready now. So welcome again to the second day of our conference, the 6th International Pain Forum and Cadaveric Workshop. We hope that yesterday everyone have had a good rest and enjoy your time in Bangkok. Yesterday we already gained a lot of knowledge of updated information and data about the management of chronic pain, non-cancer pain, like neuromodulation, the neuropathic pain, and regenerative medicine. And today we're going to move into another really important session about the cancer pain management. And as always, we are honored by several speakers who are an expert in this area. The first session is about the currently opioid situation and pediatric pain management. And the moderator in this session, I think that everyone has been familiar with her already. Ladies and gentlemen, please welcome Assistant Professor Prani Rashta Mukhayanan.
Good morning again. Today we have a theme of cancer pain. So what we talking about today is we cannot talk about cancer pain without opioid, right? Okay, so it's my honor today to introduce the speaker, the first speaker for today. She was previous head of Sirirat Pain Clinic before Dr. Nantasorn. Okay. Clinical Professor Dr. Wanna Sirojanakul. She is working in Department of Anesthesia, Faculty of Medicine, Mahidol University. Professor Wanna finished her medical degrees and anesthesia training from Mahidol University, Sirirat Hospital. Then she was a pain fellow at Rick Hospital, Copenhagen University, Denmark, and also she was a pain fellow at Mayo Clinic in the United States of America. She involved in a lot of administrative work. She was a past president of Royal College of Anesthesiologists, Thailand, and she was immediate president of Faculty of CNET, Mahidol University. Now she already retired, but she's a volunteer work coming to pain clinic twice a week. Okay, so please give an applause to Professor Wanna Sirojanakul.
Thank you, Ajahn Prani. Good morning, everybody. It's my great pleasure to be here to give my presentation about the opioid because I was one of the committee in the narcotic board of the FDA Thailand. Just passed from the work last year. So I have the data from the FDA about the opioid situation in Thailand. Yes. Before, I would like to thank you, Mr. Morakot Jarunwatana. He is the director of the Narcotic Revolving Fund from the FDA. That he gives the report of the narcotic in medical service by the year 2017. Yes, he just gave me last year. And this report is not permitted by the committee of the narcotic board, so I cannot upload the slide to all of you by this time until the executive board was approved this data. The next one is the Mrs. Nayana Pacharapaisan. She studied about the hospital pharmacist knowledge and attitude towards the opioid medication for cancer pain management. Her report was presented in 2016. And all my slide and the data is come from Mr. Morokot and Mrs. Nayana. So I would like to thank you them. The history of pain management in Thailand. The first pain clinic was established in this hospital, in our Sirirat hospital. The first one is the acupuncture and pain clinic. And 1989, the Sirirat hospital have changed the policy to change the acupuncture clinic to the multidisciplinary clinic, pain clinic. So we have the 30-year anniversary this year. 1990, Professor John D. Lucens came to Thailand and encouraged our doctor to establish the Thai chapter of the IASP Thai chapter. And so by that time, we gather a group of the doctor who interested in pain management and do work about the pain management and education since 1990. 1997, we just have the syrup morphine in Sirirat Hospital. By the year before that, we did not have any oral narcotic. We have only injection. 1997 is the enforcement and the motivation of Dr. Pong Parade, who set up the syrup to do the syrup morphine in Sirirat Hospital. By that time, we did not know that is this illegal to do the syrup morphine, because they have the law for the regulation of the narcotic. 2001, we have the universal coverage policy. And by this time, the accessibility of the drug, of the narcotic, have the increase, because more of the population can access to the hospital. 2002, we changed the Thai chapter to be the Thai Association for the Study of Pain. And in the same year, morphine slow release tablet just import in Thailand until present. Yes. 2006, the pain management program about the postoperative pain and palliative care is introduced by the hospital accreditation. So the hospital who would like to have the accredit, you have to set up the palliative care and post-op pain management, and this is make the pain visible in the hospital, because we know that most of the surgeons did not see the pain is the important issue. Yes. And just only 2010, morphine immediate release tablet and morphine solution was produced by the GPO and of the FDA, Thai FDA. In Thailand, we have the law regulation about for Thai people คือพระราชบัญญัตินะคะ Act เนี่ยคือพระราชบัญญัติเพิ่งรู้เหมือนกันว่าใช้คำว่า Act นะคะ we have the Act to control of the psychotropic drug narcotic control นะคะ the last one to 2002 the narcotic addict rehab this law is for the treatment of the people who want to quit the drug abuse. Yeah. And they did not have the punishment if they have the problem of the addiction. The narcotic acts, they divide the narcotic into 5 categories. I think it's same as the other country. The category 1 is the drug that did not use in the medical condition at all includes the heroin, amphetamine, and methamphetamine. The category 2 is the medical that we use in the medicine. Remifentanil, oxycodone, and carbendazole just import to Thailand just two years ago. 2015, I think is for oxycodone. And remifentanil and carbendazole we have around to have in our country. But so far, remifentanil did not have any company to import to Thailand. Yeah. The category 2 is the combination drug that have the mixture of the narcotic, yes, like the cough suppression, codeine. Yes. Category 4 is the substance that of the precursor of the category 1 and 2, that is acetyl anhydride and acetyl chloride. The last one is the plant, include the kathom and gancha. So still now, I think this still have is in the control of the narcotic board. The amount of the narcotic that allow for use in the kilogram base, we used very low. Formerly we used very low, but until 2010 that we have the morphine syrup and morphine immediate release tablet. So the use of the morphine is increased. Oh, I'm sorry, I didn't forget to tell that before the year 2010, only Sirirat and the Cancer Institute can produce syrup morphine. So the patient cannot, no hospital have the syrup morphine to use. So it's very difficult for the cancer patient to access to the morphine syrup because everybody have to go to Sirirat Hospital or Cancer Institute. So after the year 2010, morphine syrup and morphine immediate release tablet produced by FDA Thai, so they can buy it by themselves and so prescribe it in their hospital. Okay. And after that 1 year, we saw that the data of the morphine is increased, maybe double, from 150 to 250 milligram. And now actually you can see that even we allow the dose of the morphine to 200. But actually, we use it only 75% of the allowed by the law. And fentanyl also. Codeine, we use only 50%. About the methadone is 1/3 of the allowed by the narcotic board. Thailand is the member of the National Narcotic Control Board, NICB. So we have the data from that National Control Board, yes. By the year, sorry. Okay. And the data was shown from the 1980 to 2015. We use morphine and fentanyl only 1.5 milligram per person. The total morphine equivalent is 6 milligram per person. Please remember the number, this figure. If we minus the methadone, the total morphine we use is only 3.5 milligram. Because the methadone is used for the people who want to quit heroin addiction. And the hospital that did not have this clinic, so you do not have the allowed to buy the methadone from FDA. And this is the United States. And I think this in the next section, maybe you will, as Professor Chai will talk about the USA crisis of the opioid. You can see the number. Here is 200. That means the people in the United States use the morphine more than over 200 milligram per person. In Thailand, we use only 3.5. It's very low. It's really low. Okay? Okay. We see our nearby country, Malaysia. Malaysia use 60, around 60 to 70 milligram per person. This is from Malaysia. And when we compare to the Southeast Asia regional office, the opioid consumption in morphine equivalent is only 1.7. This is in Southeast Asia. That means Cambodia, Laos, Myanmar, Vietnam use very low about the narcotic. And so in all this country, they have the less narcotic to use. The National Board of the Narcotic in Thailand, they set up the number, the magic number, I call it the magic number for the hospital to buy, allowed to buy the narcotic. For the government hospital, they are allowed to buy morphine, not more than 400 milligrams per year, and codeine is 200. For the private hospital, they allow only 50 morphine and 60 codeine. In the clinic, by that time, they allowed to buy the codeine also. This is before the year 2006. Okay, since 2006 until present, okay, the magic number increased 10 times, from 400 to 4,000 grams, because we have the narcotic in oral form, morphine in oral form and syrup. And so the physician can prescribe more, so the use is increased. So do the private hospital. They increase the dose of the morphine and fentanyl also. But in the clinic, they did not. Now we did not allow the clinic to prescribe codeine, because the codeine is the precursor of amphetamine. They just know in not maybe 5 years or 10 years ago. So they did not allow the clinic to have the codeine anymore. Sorry. Okay. And oxycodone just come in 2015. So they, for the clinic, we did not allow. Yes. Okay. What type of opioid do we use most? Okay. For the codeine, we have only codeine tablet, no injection form. Tablet, we have 2 forms, is a 15 and 30. Most of the physicians did not know we have 30 milligram tablet. So the common use is 15 milligram. That did not enough for the pain management. If you have to take more. But this data did not include Tylenol with codeine, because Tylenol with codeine did not in the control of the narcotic board. I don't know why. And by the hospital, the government hospital, okay, they have the prescribe the codeine is more than the private hospital. We just know from this data, the veterinary use, so the animal can use codeine also. And about the morphine slow release tablet, most the commonly form is the morphine MST 10 milligram and 30 milligram, and the Capanol is 20 milligram. So this is the most common we use. So in the high dose, like the Capanol, 50 and 100 is very low to use it in our practice. That means our doctor, our physician, reluctant to give opioid or fear of addiction. I'm not sure about the data. Yes, but we saw from this data that we use very low dose of the narcotic. This is the morphine immediate release, yes, in the form of the tablet and syrup. So because of the syrup, in Sirilat, we use it more than nearly 20 years. So some of the physicians familiar with the morphine syrup. So the morphine syrup is used more than the morphine IR. Distribution by the hospital, okay, the government hospital prescribe the morphine is much more than the private hospital. This is the fentanyl injection form, but the fentanyl injection maybe is used by anesthesiologist. This one for the cancer pain management, fentanyl transdermal patch. The most common use is the 25 and 50 microgram per ounce. So the 12 microgram is used less. By the hospital, distribution by the hospital. If we see the ratio, compare the ratio, the private hospital by the fentanyl patch more than the government, because the price, fentanyl patch is expensive when we calculate per day. It's more expensive than the patient to take oral morphine. So the price is expensive, so private hospital can afford, and private patient also. The methadone, okay, is the use of the solution, because the methadone solution is for the heroin addict. The methadone previously, formerly, they did not allow for the treatment of pain. Just narcotic board allowed by the year 2011. Before that time, we used methadone for pancreatitis pain, for chronic abdominal pain. That is the off-label drug. They did not allow. Just 2011 allowed the methadone for the treatment of the cancer pain or other pain type. The government hospital, okay, they have the heroin clinic, so they use the methadone is more than the private hospital. Oxycodone, the new one of the narcotic that came into Thailand. Yeah, we have the two form, is a 10 milligram and 40 milligram. The dose is increased year by year, because now I think the more physicians know how to use this kind of medication. And the distribution by hospital, the private hospital is used more than government in the ratio of the patient, because again, it's an expensive drug, medicine, yes. And the oxycodone is a non-essential drug. So in the government hospital, the physician have to declare why you use the patient have to use oxycodone instead of morphine. So we start with morphine first. And if they have the problem with morphine, okay, we can switch to oxycodone. But you have to have the reasonable. This data come from the Kunayana. He sent the questionnaire to overall of the 323 hospital. There is the big government hospital is a 93, community hospital 150, and private hospital 82. From the data, only pain clinic have only 28% in all the hospital, and mostly in the big government hospital is 46. When we see about the morphine tablet and morphine solution, yes, most of the hospital only have the 50%. In the big government is 66, and the private hospital is 45. But the morphine IR, morphine slow release tablet, we use with in the high frequency, because this medication came to Thailand since 2002. So many physicians know about how to use the morphine slow release tablet. So the number is increased. Yes. What the fentanyl transdermal? This is for the people who have the cancer pain. 50% in the big government, and in the private hospital is 65. So the private hospital is use fentanyl transdermal more than in the government. And also it did like the oxycodone that I previously told that because of the price, the cost of the treatment. The barrier of the situation of the opioid in pain management, they summarize into 3 categories: is the healthcare personnel, policy and law regulation, patient and family barrier. For the healthcare personnel, lack of knowledge is the problem, wrong attitude, fear of addiction, and reluctance to give opioid, inadequate training in pain management, and failure to enforce the guideline to standard. This is the problem. So I think the Royal College of the Anesthesiologists, we have to encourage the pain management program to be the fellowship in pain management and have the board of the pain for the doctor. And so I wish that we have the pain specialists more and more in the future. The barrier for the healthcare policy, the problem is the drug availability, limit of drug supply. That is the problem of in the community hospital or in the government hospital outside Bangkok. They have the problem of to buy have the complicated process. They say it's a ยุ่งยากซับซ้อน it's a complicated process for buying the narcotic. They use a lot of paperwork for buy the narcotic in time to time. And sometimes the FDA have the problem. They have the shortage of the narcotic. The accessibility, some hospitals have the limit of the dosage to prescribe for the physician. So you cannot prescribe the narcotic to the patient in a lot of amount. So you have to prescribe month by month. This is the problem And it's amazing about some hospital, they have the limit item. Sometimes they allowed to import, to buy the morphine, MST only 10 milligram and not 30 milligram. They allow only this one, or morphine solution, not morphine IR tablet. This is the problem we found from the questionnaire and from the hospital, even in the government hospital. This is in the problem in the government hospital. For the private hospital, did not have this problem. They have every item, every dose of the narcotic. And the law regulation is the problem. Healthcare policy, how to comply. 30 baht policy, the health for all. This is the imagination, the dream, impossible dream of the country. Because the narcotic is expensive. I think if we can produce narcotic by our triangle in the northern part, maybe the price will be low. Okay. The next barrier is the patient and family, about the failure of the communication or miscommunicate, fear of addiction. From my experience, I saw the patient with the cancer patient, fear of addiction, but non-cancer did not fear anymore. Wrong attitude, wrong belief, and the education, nature, and the religion barrier. This is the barrier of the patient to get to the access of the narcotic. Socio-economic problem also. I think this may be all of my topic today. Thank you for your attention. If any question.
Thank you, Professor Vanna, for the very informative lectures. I must admit that I'm doing pain clinic for a long time, and today I just hear very informative things about the opioid. So anyone want to discuss about this issue? Maybe just one question. Actually, in TASP, they have some session about discussing about the opioid problem in Thailand as well. But อาจารย์วราพรอยากจะคอมเมนต์อะไรไหมคะหรือว่า Okay, so if there is no sorry อาจารย์ปัญญาพิญโยอยากจะ discuss อะไรไหมคะ we have our consultant from palliative care team ศิริราช hospital Okay, so Ajahn Vanna already sum up all the problems and barrier of opioids problem in Thailand. So our next session this year actually is thank you very much, Ajahn Vanna. So this year is actually the global ISP launch the theme for this year, that is the global year against pain for vulnerable patients. So who is the vulnerable patient? So it's like children or elderly or maternity, and one of our theme today we have a cancer pain about children. Can we open the light, please, just to see the face of our two nice speakers here? We need to show off their face. Yes, I would like to introduce two speakers of this session. The first one, Assistant Professor Sahat Samandi. The second one is Dr. Thanika Kietchai. Both of them is working in Department of Anesthesiology, Faculty of Medicine, Siriraj Hospital, Mahidol University. Dr. Sahatsa, she finished her medical and anesthesiology training in Sirat Hospital, and then she had her subspecialty training in pediatric anesthesia and pediatric pain medicine at Dalhousie University, Canada. And also Dr. Thanika, she finished from Sirat Hospital as well, her medical degree and anesthesiology degree. Then she was a research fellow in pediatric anesthesia, University of Washington, USA. Then she was a clinical fellow in pediatric anesthesia and pain medicine at Dalhousie University, Canada. So please welcome our two nice ladies, two speakers here.
Thank you very much, Ajahn Prani, for introducing us. And good morning, everyone, again. Today, my talk is about the cancer pain in children, the neglected child. So, outline of my talk is about the cancer pain in children and the prevalence of the cancer-related pain that we did some study in our institutes, and about the pain assessment. Why we call the cancer patient is the neglected child? Because I think there are something in common with the nature of pain in children. Mostly, they often under-medicated because they have the communication problems, and they also have the problem about the variety of the development and a variety of the pharmacologicals and cognitive function. So that's why in this group of the patient, normally they get lower medication that they lower than they need. So the most common cancer in children is different from adult in some natures. You can see the mostly type of the cancer that see in the children is the leukemia and other kind of the hematologic malignancies and other kind of the solid tumor. Here is the overall incidence around the world. You can see in the younger child that normally the nature of the cancer is hematologic malignancies and other kind of tumor that we normally not seen in adult patient like Wilm tumor or neuroblastoma. And because we are going to talk about the children with cancer, so I think as our practice as a healthcare provider, we may understand about the what happened to our patients, and we can imagine what is going to be the experience about the disease. But anyway, I think it would be better that we can hear from them directly. So here is the one of the survivor. She got leukemia when she was 11, and now she gonna give us her experience when she was had cancer and treatment. So I would like to ask the participant to hear from her.
When I was depressed, hurt, and suffering. But I think the worst was when I just knew that I was sick. Of course, I felt a bit sad when I knew I was sick, but what made it worse was because I didn't know how I should react. I didn't know how bad it was, how it happened, or what was going to happen. After a few days, I started to accept it and try to act as if I was okay, and I wouldn't cry because I didn't want to put any pressure on my parents. One night my mom came to me and told me that she knew I was strong, but this is too much I could handle myself. I didn't have to keep it all to myself, and we could go through it together. And that night I cried a lot, but I felt like I just got it all out of my chest, and I knew that they were there for me. After that, doctors came talk to me about treatment and everything else I needed to know. They let me know about all the phases I'll be going through, and which that could really help me see how far I've come after some time. I wouldn't say that the path was strewn with roses, but still I was so lucky I didn't have to go through longest, toughest way of treatment. And during the treatment, I think My worst experience was with the intramuscular injection. The feeling was, it was really painful. I cried even before I just got injected, and the feeling was like I just got a worse cramp on my whole arm, and even the slightest movement of my hand or feet could lead my arms to really hurt. So I tried many things, cool pack and hello, my name is Proud. I'm 17 years old and
pain and suffering that the cancer patient has to go through. So cancer pain in children is a common and distressing symptom that associate with the cancer, not only for children, also their parents. So it arises from many various mechanisms. It's from the disease itself and also the treatment that we give to the patients. Some of our patients, they got neuropathic pain from amputation and chemotherapy. So most of them, they can manage quite well by the pharmacological management and physical therapy and also psychological strategies. But by the way, clinical audits it still revealed that more than 50% of the patient of the cancer patients, they'll report undertreated pain. So because I already mentioned about the pain-related cancer pain related. So here is the paper that we study in Sirirat Hospital from 390 pediatric patients in Sirirat Hospital. We study about the prevalence of the moderate to severe pain from the procedure in children. Here we got 19% of this group of the study is cancer patients. They got they got many types of the procedures, and in this study, only 25% of the patient got a pharmacological management for their pain. And here is the prevalence of the pain that we see in our patients. The prevalence of moderate to severe procedure pain is 62.6%, and in cancer patient is 41.9%. So it's pretty high, right? So the adverse outcome of the unmanaged pain that we already concerned, there are a lot of effect for the patients. They can decline the quality of life. They can cause the sleep disturbance, and it can change the way they perceive and they have the pain process in their life later on. And they also have the restriction them for the social activities. And for sure, it can cause the emotional and behavior problems. It can happen during the treatment, and also it can go further after treatment. If I ask myself, are there anything different from adult patients who have cancer? I think the thing that different is because now for the children, they grow up every day, they may survive from the cancer. So the experience that they have would be important for them, because when they grow up, the experience that they have in their childhood will have something important for them in the future. So here is a little pictures of cactus. I think the child with cancer is like a small cactus. When they got something happen in their life, like cancer or obstacle, it's like a cactus that don't get much water. But if they get support from the family and from us, like as a healthcare provider, sometimes we can see the cactus bloom, right? So the comprehensive pain assessment. So I got this. I think in my point of view, children and elderly have a little bit something in common in the pictures, because they have some cognitive dysfunction, right? Some cognitive impairment. Some of them may have the communication problem, and they normally come with the healthcare, caregiver. So for the assessment, we need both information from the patient and from the caregiver. The point that we have to assess is about pain function, psychosocial issue, and also personal pain goal. And don't forget to get to get a lot of input from the caregiver and analgesic that they get. So this is the comprehensive pain assessment. As we know, we have to assess about the severity of pain, and we have to use the tools that appropriate for our patient that have to appropriate with their age and their communication. And also we have to evaluate about the disease, also the medical illness that they have. Also the investigation that give us more information and more clear pictures about what is the problem of the patients. And we have to evaluate the function, that are there any limitation from pain that can restrict them to go to do something or go to school or everything. And very important part is psychosocial issue. As I think we can imagine that being have cancer in the family is not the easy thing for the patient and also for the family. So they can cause a lot of distress in the family as well. So when we have when the patient has psychological distress, it can cause a lot of problem about pain and also for being uncomfort. We have to set the personal life pain goal. What is going to be okay for them? So this level they can go somewhere. If they give too much medication, maybe they got some side effect and they're not happy for that. After assessment, what age of the patient who we take care. So normally if they can talk, the self-report is the gold standard that we have to choose at the first time. So in the case that the children old age like 3 or 4 years, sometimes they can create an easy score for us, like a little bit pain or more pain or a lot of pain, that they can say that in the child in this age group. But in the children who are unable to talk or disease is just so progressed, so normally that's very important to get the information from the parents, because they know child behavior response to pain that we may not know, because sometimes in the family they have the special, I think it's a spatial communication or spatial language in the family or something that they can communicate to each other. And in the case that the patient cannot talk or cannot rate the score by themselves, maybe they're too young or something like that, the behavioral pain scale is very important to use for assessment, like revised FRAX tools or pediatric pain profile. And here is the behavioral pain assessment that commonly used in our country. Is for example, like NIPS, FLAG, and CHEOPS. But one thing to be reminded that mostly all the score they developed for the procedure and for acute state of pain. So if you want to use this score for assess pain for a background pain of the cancers, or just to use for evaluate the pain from the nature of the tumor, maybe it cannot show up something, because this score developed when they look at the behavior when the child has pain. So, but it's also useful to use that tool when the child got some procedure or some treatment. So it can use that score as well. So here is the FRAX score that I think we are really familiar with this one. And here is the revised FRAX score. In the case that child had the cognitive dysfunction in some cancer like leukemia, sometimes we found that it happened in children with cognitive dysfunction like Down syndrome, right? So we can use this score that add more detail for behavior like sad or look worry or something like that. So this one is for cognitive dysfunction patients. And here is the self-report. It depends on the way that you assess the child. Sometimes we can use whatever that the child understand. For example, 3 to 8 years old, we can use the visual analog scale, or we can use the face rating scale. And for the child older than 8 years old, normally we can ask them the score. You can count me the number, something like that. Or if you want to use something that more, I think the number is more abstract. Like if you want to use something that the child can understand, is not too abstract for them, or they can imagine. The poker chip is a good one that you can ask them to choose the piece of pain for some for greater score of their pain. And here is the common scale that we use. It's a Wong-Baker face pain scale revised. Here is, I think there's some comments about this scale, because you can see from the face that 0 score is look smile, and for 10 score is crying. So I think they got some comment that this score may cause underrating in somewhere, in some place, or maybe they got overrating because they're not crying when you assess the patient. But actually, the thing that very important is the way to explain the patient what we're gonna use for the score, like what is this fate mean and what is this fate mean. If you can explain to the patient and they understand what you say, so that means you can use this score. It depends on the what you have in your hospital. And here is the face pain scale revised. This one is also another type of the face scale that I recommend by IASP to use, because it's a little bit different from the Wong-Baker, that this one have the face look neutral in the 0 score, and for the 10 they no tears on the face. So that's why this one is also the useful for the patient to assess. So I think it depends. It's the way that you can explain to the patient to get them understand what you wanna get the information from them. So let's move to the cancer pain management for from Dr. Thanika.
Thank you, Dr. Sahat Samandi, and thank you, organization committee, that giving me this opportunity. Next part, we will focus on management of cancer pain in pediatrics. The scope of my talk will be the multimodal anesthesia, acute cancer pain, and neuropathic pain. I think everybody is familiar with multimodal anesthesia, which gear towards opioid-sparing technique. We use non-opioid for mild pain and opioid for moderate to severe pain. We have WHO guidelines to guide us how to administer. Why? Okay, so we have non-opioid for mild pain, opioid for moderate to severe pain. We have WHO guidelines to guide us how to prescribe medication. And we have done pharmacological therapy together with medication. So if conventional therapy is not effective enough, we could have the yellow circles that add adjuvants to the therapy. And then in selected cases, if this medication was failed, we just consider invasive approach like regional anesthesia. I would like to emphasize on non-pharmacological technique. How many of us in this room is specialized in physical medicine, psychiatrists, psychologists, nurses, massage therapists, or acupuncturists? Can you please raise your hand? 2, 3. I believe there are some more. So just few of us that know very well about non-pharmacological therapy. As most of us are very good at prescribing medicine, we tend to look for what we are comfortable, which is medication, and overlook the other part, which is non-pharmacological therapy, and that is very important. How can physical therapy help us in pain management? Exercise, physiotherapy, and massage can help with vasospasm. We can let the patient try thermal stimulation, TENS, or acupuncture if this can make them better. For psychological intervention, it plays an important role in any chronic pain patient as we discussed yesterday. Pain is a sensory and emotional experience. Pain education about diagnosis and coping will help a lot. This includes cognitive behavioral therapy and family therapy. We teach the patient about sleep hygiene, relaxation, and mindfulness. These psychological strategies will help the child manage stress during acute pain episode where medication doesn't work. However, the child and the family need to learn these strategies in the quiet pain state. When pain crisis arises, the child knows how to use the strategies that they have learned, and family is able to facilitate the process. For myself, I'm an anesthesiologist and I don't know much which non-pharmacological technique is appropriate for each patient. I will go to my team for 3P, psychological, physical, and pharmacological. If these words are too complicated, the same meaning would be 3M, mind, movement, and medicine. I will ask my colleagues what they can offer, and we will work together. When you are back in your hospital, find a team. It may be difficult to begin with, but your work will be easier. The next part would be acute cancer pain management. Dr. Stefan Friedrichsdorf et al. Have reviewed in 2014 and divided acute cancer pain management into acute background pain and acute breakthrough pain. For acute background pain management, they recommended to use these 4 principles, using a 2-step strategy, dosing at regular intervals, using the appropriate route, and adapting treatment to the individual child. In 2-step strategies, step 1, WHO suggests to treat mild pain with paracetamol and/or NSAIDs. Step 2, strong opioid can be used for moderate to severe pain. Adjuvant analgesics may be added at either step to enhance pain relief. They recommended to dose the medication at regular interval or by the clock. Dosing around the clock maintains analgesic level inside the analgesic corridor. We should select the appropriate route of administration. The least invasive route is preferable by oral, NG tube, or PEG. If applicable, intravenous patient control analgesia with or without continuous background infusion can be applied. Remember, fentanyl patch is not recommended for acute pain management, even in chronic pain patients. Lastly, the treatment effectiveness should be frequently assessed, reassessed, and modified to the individual child. At analgesic level, the sedation is not expected. After we have controlled background pain, now it's time to manage acute breakthrough pain. Acute breakthrough pain can be divided into 3 categories. First, incidental pain, typically induced by a child's movement, which may require analgesic dose prior to movement, such as physical therapy. Second, end-of-dose failure. This requires adjustment of dosing regimen, such as increasing the dose or decreasing the dosing intervals. Third, spontaneous pain. Spontaneous pain can be managed similar to background pain. The last topic would be neuropathic pain management. Many children with cancer suffer from neuropathic pain. However, there are no published pediatric RCTs, no agreement on pediatric treatment recommendations, so children with cancer and neuropathic pain are often under-assessed, under-treated with ineffective therapies. That's why today's topic is called the neglected child. This slide summarizes the steps for management of neuropathic pain in children with cancer. The approach suggested in this slide may be considered, however, it should be altered depending on the age, underlying condition, pathophysiology, and treatment goals for the individual patient. Let us see each step together. Step 1. We should identify and treat underlying disease process and consider radiation or corticosteroids when CNS compression appears evident. Step 2. Start integrative or non-pharmacological therapies to help manage comorbidities such as anxiety and sleep disturbance. Now you may notice that the conventional painkillers like opioid didn't appear in the initial steps. Step 3. We start to administer an opioid. And then step 4, we add a low-dose TCA or gabapentinoid. These medications may take days to start working, so consider starting low-dose ketamine as a bridge in severe cases. Step 5, combine a low-dose TCA and gabapentinoid. So far, I will summarize step 1 to 5 as treat the disease, non-pharmacological therapy, plus opioid, amitriptyline, and gabapentin. Step 6, they consider a lidocaine patch if the pain is localized, but I don't have personal experience since we don't have one in the country. Step 7, consider other adjuvants and MDA channel blockers such as ketamine or methadone, low-dose benzodiazepine, alpha agonist, and intravenous lidocaine. Step 8, consider regional anesthesia and referral to a pediatric pain specialist if this hasn't already happened. I'm not going into the details of the last few slides. There are dosing for common opioid and adjuvants that you can refer to. Lastly, if anybody who is interested in pediatric pain management, the International Symposium on Pediatric Pain Conference will be held in Basel, Switzerland in June 2019. Please save the date and join us if you can make it. Thank you for your attention.
Thank you, Dr. Sahatsa and Dr. Thanika. Sorry, we don't have any time for the question. So if you have any question, please feel free to ask our speakers at the end of the lectures or ask our staff or Ajahn Vanna later. Okay. So for the next session, we're still talking about opioids, but we want to learn from experience from another part of the world as well. So during setting of the slide, the next speaker is my honor to introduce Dr. Thomas Chai. He is an assistant professor from Department of Pain Medicine, Division of Anesthesiology and Critical Care, the University of Texas at MD Anderson Cancer Center, Houston, Texas. His background, he got American Board of Physical Medicine and Rehabilitation, also ABMS subspecialty certificate in medicine. So please give a big round of applause to Dr. Thomas Chai.
สวัสดีตอนเช้าครับดีใจที่รู้จักทุกคน The remainder of this lecture will be in English เพราะว่า I พูดภาษาไทยไม่เป็น so I'll speak English and speak it very slowly But thank you for the introduction and thank you for having me. I thought that the lecture earlier today was very interesting about the opioid situation in Thailand, and I think the situation in Thailand does bear some resemblance to the current opioid crisis in the U.S., but there are definitely some distinct differences that I think you'll be very surprised to learn about during this lecture. So we'll go ahead and get started here. Again, this is my background. I grew up in a state in the United States called Alabama, a southern state, and I actually attended grade school, college, medical school, internship in Alabama, and I got my medical degree from the University of South Alabama College of Medicine, and received or trained in physical medicine and rehab medicine in Washington, D.C. at the National Rehab Hospital, and fellowship training in pain medicine at UT MD Anderson Cancer Center in Houston, Texas, and then I joined the faculty there in 2011. And I'm board certified in both rehab medicine and pain medicine. And this is an aerial view of what the Texas Medical Center looks like, where MD Anderson is. It's actually the largest medical center in the world. So it's when I go to work every day, I'm always amazed that I'm practicing medicine in such a wonderful institution worldwide. And these are my colleagues in the pain service. These are the people that I work with every day, and I'm very grateful to work with. Technically, this is the chronic pain service, because MD Anderson has a chronic pain service, an acute pain service, palliative care. We call it supportive care service. But we have different backgrounds. For example, my background is rehab medicine training, but we have psychologists, anesthesiologists, emergency medicine, and a number of other specialties. So definitely a kind of multi-specialty group here. Well, before I talk about the current opioid crisis in the U.S., I wanted to give you all a little bit of a background on U.S. drug regulation and policy, because it is different than the Thai drug regulation and policy. But there are some similarities too. But it all started, well, you could say in 1970, when then President Richard Nixon signed into law the Controlled Substance Act, abbreviated CSA. And this established a federal U.S. drug policy to regulate certain substances. The CSA places all substances which were in some manner regulated under existing federal law into one of 5 schedules. And these 5 schedules are based on the substance's accepted medical use, abuse potential, and safety/dependence liability. The CSA provides for a way for substances to be controlled as determined by factors, again, such as abuse potential, scientific evidence for its pharmacologic effects, current state of scientific knowledge regarding the substance, its history/pattern of abuse, the scope, duration, significance of abuse, risk to public health, psychic or physiologic dependence liability, and whether that substance is a precursor to a controlled substance. And the United States Drug Enforcement Administration, or the DEA, and the U.S. Food and Drug Administration, the FDA, determine which substances are scheduled. And this is an example of the Controlled Substance Act Schedule 1 through 5, some resemblance to the Thai scheduling of drugs, but some distinct differences as well. Take, for example, in Schedule 1 here, Schedule 1, these are substances that the U.S. federal government actually does not recognize as having any medical utility. And also these substances have a very high abuse potential, so essentially we do not prescribe any medications in Schedule 1. And some examples of Schedule 1 substances include heroin, LSD, and even marijuana. Because in the U.S., legal system is multi-tiered. There's a federal laws, and then there are individual state laws, and they may not be the same. So there's always a little bit of confusion. But under the federal level of the U.S. government, marijuana is not legal. Most of the opioids that we prescribe belong to Schedule 2, but one of the differences that you'll notice is that we are allowed to prescribe amphetamines. For example, methylphenidate. We actually prescribe that, for example, for cancer-related fatigue, and it's also FDA approved for other indications such as attention deficit hyperactivity disorders. We have then down to Schedule 3. Schedule 4, some drugs that belong in Schedule 4 are things like benzodiazepines. And then Schedule 5, pregabalin is one example of a substance that's in Schedule 5, but this is in descending order of abuse potential here. Over the past few years, there is a substance that has received some attention in the United States, and we in English or in the United States we call it kratom, but I think in Thai they call it kratom or something like that. So this kratom is a plant that is native to Southeast Asia, but it does contain compounds that have psychotropic, opioid-like effects, psychoactive type effects. And for the most part, with the exception of about 6 states in the United States, kratom is not legal. Forgive me, kratom is legal with the exception of 6 states in the United States, but and under federal law, it is not illegal. However, this medication definitely is receiving a lot of attention in the U.S. in the last few years because of these the abuse potential, and the Department of Health and Human Services, or HHS, is recommending that the Drug Enforcement Administration make kratom a Schedule 1 drug in the same category as marijuana and LSD. So it's a very dangerous drug under in the eyes of the federal government. Now that we have a little bit of a background about the U.S. drug regulation policy, I wanted to talk about why the U.S. is currently experiencing an opioid crisis and what are the origins of this crisis. Now, there are many, but I just selected a few examples to highlight. For example, back in 1980, there was a 5-sentence letter to the editor that was published in the New England Journal of Medicine entitled "Addiction Rare in Patients Treated with Narcotics." And this article was cited by hundreds of other articles, and so it turns out this is kind of an unsubstantiated claim. There has been enormous patient advocacy from both physicians, providers, and patients for using opioids for pain management. There was aggressive promotion of a number of opioids from the pharmaceutical companies. For example, in the late 1990s to early 2000s, oxycodone was heavily promoted, and what we saw was actually a 10-fold rise in prescriptions of this drug. There are a number of rogue pharmacies and unethical physician prescribing that could lead to opioid diversion. In the U.S., we call these pill mills. Very easy to get opioid prescriptions in some of these physician practices. Pain was considered by many as a fifth vital sign. It was promoted by the American Pain Society in the mid-1990s and supported by a number of other organizations such as the Federal Government's Veterans Administration, as well as the Joint Commission, which is a hospital accreditation organization. There was inadequate oversight by the U.S. FDA. Reimbursement for prescription opioids was very easy by insurers, whereas other treatments for pain, alternative treatments, complementary medicine, is much more difficult to being reimbursed by insurers. So it's just much easier just to write a prescription and get it approved by insurance to pay for it. In terms of medical education in the United States, there's definitely a deficiency in education about pain management, opioid education, screening, and treating addiction. And I graduated from a U.S. medical school in 2006, and I can attest that it is true. I received very little education, formal education on pain management when I was in training. There's a lack of patient education, and there is, to some degree, in the United States, reimbursement to healthcare providers that is tied into patient satisfaction scores and physician quality ratings. So that is a problem, because if you want to make a patient happy so that you get fully reimbursed, sometimes you have to think about whether or not you want to prescribe opioids. And then unintended consequences due to some of the recent increased scrutiny and reduced access to prescription opioids. This may have resulted in drug seekers abusing non-prescription opioids, street drugs like heroin and illicitly manufactured fentanyl, if they cannot obtain a prescription opioid. And this is happening in the United States. And treatment services for opioid use disorders is insufficient in the United States. So we're talking about things like detoxification, maintenance programs, medication-assisted treatment using methadone, buprenorphine, naltrexone, and other things for maintenance or detoxification. And there's a lack of national prevention strategies. So I wanted to talk briefly about what the federal government and state government's response is to this current problem. One example is that in March of 2016, the U.S. Center for Disease Control and Prevention, or the CDC, released guidelines regarding opioid prescribing for chronic non-cancer pain, and a number of different specialists seem to reference these guidelines and abide by these guidelines, even though they're meant for chronic non-cancer pain. And unfortunately, even in the cancer hospitals, we've had to be much more careful and due to some of these guidelines. For example, the CDC, under their analysis, their study, they discovered that 1 in 5 patients with non-cancer pain or pain-related diagnoses are prescribed opioids, 20%. Nearly 2 million Americans abused or were dependent on prescription opioids in 2014. And from 1999 to 2016, there were over 630,000 deaths from drug overdoses, with over 350,000 of those deaths involving opioids. Since 1999, sales of prescription opioids have quadrupled in the United States. For example, in 2015, there were approximately 300 million prescriptions written, which equates to $24 billion in sales. And although the U.S. has less than 5% of the world population, we consume 80% of the global opioid supply. The US has a population of about 330 million, with a world population about 7.5 billion. So, but we consume the vast majority of the global supply of opioids. For example, the US consumes 99% of the available hydrocodone. So the purpose of the CDC opioid prescribing guidelines is to improve communication between the provider and patient about the risk-benefit ratio of using opioids for chronic pain, to improve safety and effectiveness of pain treatment, and to reduce the risks associated with long-term opioid therapy, which includes opioid use disorder and overdose. But as you can see, I placed an asterisk here because these guidelines, again, were not intended for patients who are in active cancer treatment, palliative care, or end-of-life care. So this slide is just a list of the CDC guidelines. I'll go over it very quickly. Number one, again, recommend non-pharmacologic therapy and non-opioids for chronic pain, but if opioids are used, try to use them in conjunction with non-pharmacologic and non-opioid analgesics. Try to establish realistic treatment goals in both pain and function with the patient, and continue the opioid therapy only if there is meaningful improvement in pain and function that outweighs the risks. Now, before and during opioid therapy, discuss the risks, benefits, and responsibilities that the patient must comply with. And when starting opioids for chronic pain, clinicians should prescribe immediate release, not sustained release medications. When starting opioids, always prescribe the lowest effective dosage and reassess if the patient is on 50 milligrams per day of morphine or its equivalent. And avoid or carefully justify keeping a patient on 90 morphine equivalents per day or more. Now, for acute pain, use the lowest effective dose of opioid and limit the quantity or the duration to no more than, at the very most, 7 days. Usually 3 days is sufficient opioid therapy for acute pain, including acute postoperative pain. Assess risks and benefits within 1 to 4 weeks of starting and escalating opioids, and have the patient come back to your pain clinic to follow up at least once every few months for continued therapy. Taper or discontinue if the risks outweigh the benefits. Consider risk mitigation strategies, such as offering the opioid antagonist naloxone for those who are at higher risk, those with a history of substance use disorders, those who are on high morphine equivalent daily dosages, greater than 50, or are concurrently using benzodiazepines. Regularly review online state prescription drug monitoring programs, and I'll show you that in the next slide. Urine drug testing prior to and at least annually to ensure that the patient is compliant with the prescribed medication and that they're not using other medications prescribed by others and illegal substances. Try to avoid prescribing both opioids and benzodiazepines together if possible due to the combined risk of respiratory depression. And one needs to offer or arrange treatment for patients who have an opioid use disorder upon screening. Now, in the United States, I don't know about Thailand, but in the United States, 49 out of the 50 states, it might be 50 by now, but the vast majority of states have an online prescription drug monitoring program, which is a state website that the providers can log into to get access to all of the controlled substances that a patient has received in a certain time frame. So take, for example, here, if I log into the Texas prescription drug monitoring website, I can enter a patient's name, last name, date of birth. I can then select a range of dates that I'd like to search. And if a patient, resides in a different state, but they come to MD Anderson for treatment, I can select the state that they come from Not all of the states are interconnected at this time. Texas is interconnected with 26 different states, but I think that's going to be growing. So once I enter all this information, I can hit the search button, and the result looks something like this, where the patient's name is here, and in this column here, this is a summary of all of the controlled substances that are prescribed, the total number of prescriptions, the total number of prescribers, the total pharmacies, the opioids with the calculated current morphine equivalent daily dose, and this is a section for buprenorphine if the patient is on a medication-assisted treatment for opioid maintenance or detoxification. And here, as you can see in a reverse chronological order, are the prescriptions that the patient received. For example, this is when the prescription was filled, when it was written, the name of the drug, the quantity prescribed, the duration, the abbreviated clinician name, the prescription number, the pharmacy of which it was dispensed, number of refills, morphine equivalent daily dose, insurer, who paid for the medication, the insurer, and the website or the state in which the medication was filled. So this is a very useful tool that we have to monitor patients. Well, 1 year later, in March of 2017, this gentleman, if you don't know, his name is Donald Trump. He is the U.S. president, and President Trump formed a commission to address this opioid issue, and this is the commission is called the Commission on Combating Drug Addiction and the Opioid Crisis. It was chaired by former New Jersey Governor Chris Christie, and in November of 2017, the commission released its final report with a summary of recommendations for the president on how to combat the opioid crisis. And listed here are just select examples from the 56 items in the summary of recommendations. The commission recommended to the president to launch a the commission recommended to the president to launch a mass media campaign to address the hazards of substance use, the danger of opioids, and stigma. And this means television, radio, social media, internet, etc. Develop policies to ensure informed patient consent prior to starting opioids for chronic pain. Develop a national curriculum and standard of care for opioid prescribers to supplement the CDC guidelines. Make mandatory or mandate the prescription drug monitoring program checks. As a matter of fact, in the state of Texas, this September, it will be mandatory for all clinicians who prescribe controlled substances to check the monitoring website before seeing a patient and prescribing for them. Integration into electronic medical record systems, add supplemental data such as opioid or overdose episodes, and increase the utilization of electronic prescribing of controlled substances. For example, at MD Anderson, we prescribe controlled substances through electronic means rather than writing a paper script. We've moved away from that, and now we prescribe electronically. It can there's less likelihood that some bad people can take the prescription and try to duplicate it, or because that has happened years ago. Electronic prescribing is supposed to be a little bit safer. Encourage widespread availability of drug take-back programs. The U.S. DEA holds semi-annually drug take-back programs where patients who have leftover medications can come to these community events and they can dispose of safely their used medications, including their opioids. This is not available, or it's not widespread, but the government is encouraging pharmacies and hospitals to make these programs more widely available, so that patients don't have medications at home, which could then be diverted or stolen. We do recommend that patients either flush medications down the toilet or mix the medication with, cat litter and throw it away in the trash or something like that if they cannot dispose of the medication at a drug take-back program. And there are some other things that we can give them, solutions that deactivate the medication. There are special deactivation type of solutions and powders and things like that. Now, try to remove pain survey questions on the patient satisfaction surveys so as not to incentivize providers to offer opioids to raise their patient satisfaction scores and quality ratings. Try to enhance penalties for those who are trafficking fentanyl preparations. This is a very big problem in the United States right now, is illicitly manufactured fentanyl coming in from places like China. Expressly target drug trafficking organizations and individuals who produce or sell counterfeit pills, including through the internet, which is very difficult in the Silk Road and the underground markets, the deep web, or the dark web. Use additional tools at U.S. Customs and Border Protection to intercept fentanyl in mail processing distribution centers. For example, they've trained canines to be able to detect fentanyl. Improve screening and referral for substance use disorders, and enable processes to divert low-risk, nonviolent drug offenders with a substance use disorder into a drug court rather than imprisonment. Because if you divert these drug offenders to a drug court, that's where they can receive treatment and get back into society to contribute to society rather than go to prison. Develop and test innovative medications for substance use disorders and opioid use disorders. Again, opioid use disorder is a pattern of opioid use that can lead to severe impairment and distress. But develop drugs such as long-acting naloxone injections, more potent antagonists to reverse overdose, new detoxification drugs, and even opioid vaccines, such as a vaccine that will dull the effects of heroin and fentanyl for people who are at risk. And Francis Collins, who's the director at the NIH, is one of the people that are working on some of these new drugs. Now, around October of 2017, around Halloween, as you can see by this picture, President Trump declared the opioid crisis as a national public health emergency under federal law. And once he declared this as a national crisis, it enabled federal funding for programs to help address the issue. I think I may have missed a slide, but and that was October of 2017. In April of 2018, the United States Surgeon General, Jerome Adams, MD, the U.S. Surgeon General is like the federal spokesperson for public health issues. He actually released an advisory on naloxone and opioid overdose, and what it says is that for patients currently taking high doses of opioids as prescribed for pain, individuals misusing prescription opioids, individuals using illicit opioids such as heroin or fentanyl, healthcare practitioners, family and friends of people who have an opioid use disorder, and community members who come into contact with people at risk for opioid overdose, knowing how to use naloxone and keeping it within reach can save a life. So there's a recommendation to prescribe naloxone with the opioid prescription, and there is an intranasal spray, 4 milligrams of naloxone actuator device here that we do prescribe, and the Surgeon General is recommending that we prescribe so that the caregiver can contact emergency services, but in the meantime, rescue the patient while waiting for help. And so this is definitely recommended now in the United States. Now, this might be the last slide. Now, in September of 2018, the Opioid Crisis Response Act has been is a bill that has been passing through the legislative arm of the federal government, which is Congress, and it's once it makes it to the president, once this bill makes it to the president, it can be signed into law, but it's going through Congress right now. But some of the select provisions from the bill is that there is going to be state funding to combat the opioid crisis, improvements to the prescription drug monitoring program, grants to create opioid recovery centers, grants to medical schools and teaching hospitals to support medication-assisted treatment training, again, methadone, buprenorphine, naltrexone, and grants to hospitals to develop alternative strategies to opioids for pain management. And I hope that one day you can come to visit the United States or even the state of Texas and come visit us at MD Anderson. These are some of the state symbols, the flag, the seal. This is called this mammal is called a longhorn, and northern mockingbird and a bluebonnet. And I hope one day you can come visit. Thank you.
Thank you very much, Dr. Thomas Chai. It's very interesting to see, another extreme in another part of the world. So we have a lot of time to discuss in this session, and we have more time before the break. Anyone want to discuss about opioids or want to ask anything? ถามเป็นภาษาไทยก็ได้นะคะเดี๋ยวจะแปลให้ or ask in Thai and I can translate. Okay, Dr. Nantasorn, please.
If we combine two lectures together, Ajahn Vanna first and then by Dr. Thomas Chai, we can see the contrast on the opposite side of the world. One part of the world kind of lacking of the medications and underutilized the opioids. And another part of the world, we have a problem with the overuse of the opioids. The question is how much is enough and what is the exact amount that we should give to the patients. And then I think the answer of that question probably not how much, but to whom. I mean, if we have a good patient selection, probably that will take care of a lot of the problem. Usually for the cancer patient, we tend to liberal about the opioids, and in the CDC guidelines always mentioned, I think it's stated in their CDC guideline about 20 times that there is no evidence for the long-term benefit for opioid for non-cancer patients, and I rarely prescribe opioid for non-cancer patient. I think I never, to be honest. But anyhow, the next phase of the challenge is even cancer patient is not homogeneous though. The cancer used to be a terminal disease patient, which opioid is not a problem. But now cancer turned to be the chronic disease. And cancer survivor who on the huge dose of opioid probably gonna be a problem in next 5 to 10 years or probably right now.